Hypoparathyroidism is uncommon. In fact, a major cause of this disease is accidental surgical excision, and this can occur during thyroidectomy. On the exam, be on the lookout for a patient with symptoms of hypocalcemia after thyroid surgery. However, hypothyroidism can also come from autoimmune destruction of properly functioning glands, or agenesis of the glands, as seen in DiGeorge syndrome. Now remember, when there is not enough parathyroid hormone being produced, the major result is hypocalcemia. So, do you remember any physical exam findings that we can see with hypocalcemia? One is Chopstick sign, and this is where you tap the facial nerve to look for signs of facial muscle contraction. Another is Trousseau's sign, in which you occlude the brachial artery for a few minutes using a blood pressure cuff and look for spasm of the carpal muscles of the hand. You are unlikely to be tested in these names, but you may hear the descriptions in physical exam findings, so pay attention to this. Another important cause of hypoparathyroidism is known as pseudo-hyperparathyroidism, also known as Albright's hereditary osteodystrophy. Interestingly, these patients have low serum calcium but high PTH. Now, why do you think that's the case? Well, it turns out that the kidney does not respond to the PTH signal, and therefore you have decreased production of 1-alpha hydroxylase, which eventually leads to decreased calcium resorption. Key features of this disease are it has an autosomal dominant inheritance, and on physical exam, these patients are often short, obese, and their hands have particularly short 4th and 5th digits. Shortened digits is also known as brachydactyly. And you can see in this photo what I'm talking about. And on X-ray, you can see that the metacarpal bones are extremely short. Okay, so flash quiz. Which type of thyroid cancer cannot be diagnosed with fine needle aspirate, and instead requires a physician to perform a core needle biopsy? The answer is follicular thyroid carcinoma. One needs to have intact tissue with intact blood vessels to make this histopathologic diagnosis. Let's move on to the pituitary adenomas. The MRI image displayed here demonstrates a large pituitary adenoma, or macroadenoma. As you remember, the pituitary gland is responsible for the secretion of numerous hormones, and a pituitary adenoma is capable of secreting any one of these. However, the most common functional type of pituitary adenoma secretes prolactin, and it is appropriately called a prolactinoma. Can you think of some of the signs and symptoms a person might have with this? Well, galactorrhea. And if you remember that prolactin can have an inhibitory effect on GnRH, then you'll remember that these patients also present with amenorrhea, low libido, and infertility. Drugs used to treat this condition rely on the inhibitor effect of dopamine on prolactin secretion, and examples of dopamine agonists are bromocriptine and cabergoline. When a pituitary adenoma grows sufficiently large, you can also have another key symptom, and this requires you to remember your neuroanatomy. If you recall, the pituitary gland sits in the sella turcica, and above this you have the optic chiasm, as shown here. And this is where the nasal fibers that carry information from the temporal fields cross. If the tumor grows very large, it can compress the optic chiasm. And what do you think would be the effect on the patient's vision? Right, they'll lose their peripheral vision. And this is a condition known as bitemporal hemianopsia. Let's quickly break that word down so you can remember it better. Bitemporal, because both temporal fields, hemi, meaning half the visual field, and anopsia, meaning lack of vision. Acromegaly is a condition that results from excess growth hormone in adults after epiphyseal plates have fused. In most patients, high levels of GH, or growth hormone, are a result of a pituitary adenoma. However, professional athletes like bodybuilders who use growth hormone to improve their athletic performance can also develop acromegaly. Notable features of acromegaly include a large tongue, deep voice, large hands and feet, and gaps between the teeth. In addition, classically you'll be presented with a patient who says that their hat and shoes no longer fit, and if you ask them to compare a picture from 15 years ago to now, you would notice that their facial features have changed dramatically. You may also recall from our physiology lecture that it decreases glucose uptake in fat and muscle. Do you remember what a long-term consequence of that is? Insulin resistance. Diagnosis requires the measurement of insulin-like growth factor. This is a great screening test for this disorder. You can also do a glucose suppression test to confirm this diagnosis. Normally, elevated levels of glucose should decrease the production of GH, but in the case of acromegaly, these levels will remain high. Lastly, treatment of a pituitary adenoma that is causing acromegaly is surgical resection. It can also be managed medically with octreotide, a somatostatin analog, which blocks the secretion of GH. It is often used in patients with residual tissue after surgical excision. Now we're going to cover two conditions that are related to the ADH hormone, but their clinical presentations are completely different. The first is diabetes insipidus. Now you may already know about diabetes mellitus, which is due to decreased insulin production leading to high blood sugar levels. These patients commonly present with polyuria. In the old days, what was notable about the urine was that it was sweet and would attract ants. The reason for this was that there was glucose in the urine, hence the name diabetes mellitus, where mellitus means honey sweet. Now with diabetes insipidus, we have another case where a patient is producing too much urine. So it looks a lot like a case of diabetes mellitus, but in this case you do not have that sweet taste in the urine. And that's because there's no glucose in the urine to cause the polyuria. Rather, it is bland and tasteless, hence the name insipidus. So what is the underlying cause of the polyuria? Ultimately, it is related to the disruption of normal function of antidiuretic hormone, also known as vasopressin. Normally, this hormone allows the body to resorb free water. So let's talk about the two types of diabetes insipidus. It is important for you to understand the fundamental concepts of these conditions for your test. The first type is nephrogenic, in which the kidney is not responsive to ADH. This can occur in the setting of a hereditary disorder involving a mutation in the ADH receptor, and it can be secondary to hypercalcemia, or as a side effect of medications, including lithium and demycocycline. Demycocycline is interesting because it is a drug that is specifically used to get this ADH insensitivity effect, but more on that later. The other type of diabetes insipidus is called central diabetes insipidus because it refers to the central nervous system. In central diabetes insipidus, there is a decrease in production of ADH. There are many causes, including damage to the hypothalamus where ADH is produced. Also, a pituitary tumor that does not release ADH secondary to, for example, head trauma, and this can occur in a patient who was in a car that was moving very fast and suddenly stopped, and this motion or momentum in the brain causes severing of the pituitary stalk, leading to loss of blood flow in the posterior pituitary. So as I mentioned, all these patients will have polyuria. As a consequence, they will be very thirsty. Lab testing will show that they cannot concentrate urine. In particular, urine-specific gravity is less than 1.006. In addition, serum osmolality is well above 290 milliosms per liter. Sometimes it can be confusing as to what the cause of the patient's polyuria is, and we can figure out the underlying cause using what is known as the water deprivation test. In this test, we deprave the patient of water and measure the urine osmolality before starting the test and after a certain period of time. Then, again after the administration of desmopressin, which is an ADH analog that stimulates ADH receptors. Normally, one is able to conserve free water by resorbing more, and hence they will concentrate their urine, and the serum osmolality measured would be increased. However, in the case of the patient with diabetes insipidus, this ability is lost. Now, what do you think happens in the setting of central diabetes insipidus? Right, the osmolality should go up, because it's a problem with the production of ADH in these patients. Now, what about nephrogenic diabetes insipidus? Well, we shouldn't see much of a change, since these patients are unresponsive to ADH. This is a key concept that the boards love to test you on. Knowing the expected outcomes of the water deprivation test is often tested, and we'll apply this concept in a few other conditions that we will discuss in a minute. As far as treatment is concerned, patients with central diabetes insipidus can simply take a synthetic ADH analog, desmopressin, because they are just not making the ADH. Nephrogenic diabetes insipidus, however, is much harder to treat because ADH is present, but the kidneys are non-responsive. The main drugs for you to be familiar with for this condition are hydrochlorothiazide, amiloride, a potassium-sparing diuretic, and indomethacin, a non-steroidal anti-inflammatory drug. The thiazide and potassium-sparing diuretics reduce sodium resorption and increase water loss in the distal regions of the nephron. The resultant hypovolemia induces the body to respond by upregulating aldosterone, leading to sodium and water resorption in the proximal nephron. Indomethacin is an NSAID, which will decrease levels of prostaglandins. And as it turns out, prostaglandins play an important role in inhibiting the effect of ADH on the kidney. So if we block prostaglandins, then ADH can function more effectively. Now let's discuss the syndrome of inappropriate antidiuretic hormone, or SIADH, which, as the name implies, is due to too much ADH. Recall from the renal lectures that one of the main functions of ADH is to insert aquaporin II channels into the collecting duct membrane and enable the resorption of water in the collecting ducts. So what do you expect the effect of inappropriate production of ADH to be? Well, you would see excessive water retention, and the excess water would dilute the serum, leading to low serum osmolality and hyponatremia. Furthermore, the increase in fluid volume leads to a decreased production of aldosterone, so even less sodium will be resorbed, and this will lead to hyponatremia. Management of hyponatremia is very important because if left untreated, it can lead to a number of neurological side effects, such as seizures. Treatment of hyponatremia depends on serum osmolality and volume status. In short, if a patient has hypotonic hyponatremia and is volume depleted due to SIADH, IV normal saline is used. You may think, well, let's avoid these seizures and fix the sodium right away with hypertonic saline. But there's a reason we don't do this. Do you remember what it is? Well, it can lead to central pontine myelinolysis, also known as osmotic demyelination syndrome. Here's an MRI demonstrating an area of demyelination in the pons. Symptoms include acute paralysis, dysphagia, dysarthria, and other neurological symptoms. This is an important association to remember for the exam. So why does this happen? Well, when you have a prolonged period of hyponatremia, your cells will excrete sodium, potassium, and chloride so that it can maintain equilibrium with the surrounding hypotonic environment. This excretion of osmotically active substances prevents neurons from undergoing osmotic lysis, or swelling to the point of rupture from excessive osmosis. Now let's take our patient with SIADH, who is hyponatremic. Let's say we decide to correct this by giving them a large amount of normal saline, which is an isotonic solution. In this case, we are starting with a hypotonic solution, and we are adding more sodium and chloride with our IV fluid to bring it back to normal. So what does this mean for the brain cells? The cells will lose water and shrink, a process known as plasmolysis. The most commonly tested subtopic on SIADH, aside from electrolyte disturbances, is the underlying causes of SIADH. The major causes are CNS secretion of ADH from CNS tumors, head trauma, and stress from surgery. In addition, ectopic secretion of ADH can be seen in small cell lung cancer, TB, sarcoidosis, or other pulmonary diseases, and drugs such as cyclophosphamide and carbamazepine are also known to increase ADH secretion. As described earlier, in the hypovolemic patient with hypotonic hyponatremia, we use normal saline, but if a patient were euvolemic, then the treatment would simply be water restriction. If their condition continues to worsen despite water restriction, then you could consider a pharmacologic approach. Do you know what drugs are used in this setting? Well, one drug we have already mentioned. This drug causes diabetes insipidus, which is the complete opposite effect of SIADH. Do you remember what drug I'm referring to? Demikocycline. There are two other drugs that act as vasopressin or ADH receptor antagonists, which include conivaptan and tolvaptan. Of note, there's also a phenomenon known as psychogenic polydipsia, in which a patient presents and looks a lot like he or she has SIADH, but it turns out they're merely drinking too much water. And in order to diagnose this, all you have to do is a water deprivation test. Okay, flash quiz. What are the expected findings in a patient with nephrogenic diabetes insipidus undergoing a water deprivation test? The answer is C. Plasma osms are high because the patient is not resorbing water, and consequently, urine osms are low. Recall that plasma ADH in nephrogenic diabetes insipidus are high because the kidneys do not respond to circulating ADH, and it is not a problem with underproduction. Furthermore, after administration of desmopressin, the urine osmolality is relatively unchanged. Answer B is a normal water deprivation test, and answer A is what we would see in central diabetes insipidus, with a low plasma ADH but a relatively good response to the administration of desmopressin.